Hello friends, welcome to this important module on hereditary hyperbilirubinemia. So you have read about the module on jaundice, right? So you are very much clear what is conjugated hyperbilirubinemia and what is unconjugated, right? So whenever we are dealing with hereditary hyperbilirubinemia, it is divided whether it is a conjugated hyperbilirubinemia or it is a unconjugated hyperbilirubinemia. So we call it conjugated when the direct fraction is more than 15% of the total bilirubin. So that's what is conjugated. In conjugated, we have two disorders. One is the Dubin-Johnson syndrome and the other is the Rotor syndrome. And in unconjugated, we have Crigler-Najjar syndrome and the Gilbert syndrome. So sometimes from this chapter, you get one or two MCQs, right? So that's why I've created this as a separate module, okay? So before we go into the disease proper, let's just go through the bilirubin metabolism once again. So now we are skipping the initial part of the bilirubin metabolism where it is formed. We are coming to the fact that bilirubin is being bound to albumin. Now this is a insoluble form of the bilirubin. To make it soluble, it has to be conjugated. It has to be conjugated. So this bilirubin enters the liver. It enters the liver. Now this is the sinusoidal membrane. This is the sinusoidal membrane and this is the canalicular membrane, right? This is the canalicular membrane. So the bilirubin that enters the liver has to be conjugated by an enzyme known as UGT1A1, which is nothing but a uridine diphosphoglucuronosyl transferase, right? Uridine diphosphoglucuronosyl transferase. So once the bilirubin gets conjugated, now this bilirubin is water soluble. This bilirubin is now water soluble. But what is the rate limiting step? The rate limiting step is the excretion of this bilirubin with the help of a canalicular protein known as the MRP2. Now, defect of this protein basically gives rise to Dubin-Johnson syndrome. We'll come to it again, but you remember it right now with the diagram. That defect of this protein gives rise to the Dubin-Johnson syndrome. Some of the bilirubin would escape outside via protein known as ABCC3. ABCC3. Now these are some important numbers that you need to remember, to which it is again taken up. This is again taken up. Now some of the bilirubin, understand this mechanism, some of the conjugated bilirubin that escapes from the liver is being again taken up by another transporter that is known as the organic anion transporter 1B1, 1B3. Organic anion transporter 1B1, 1B3. Now the defect of this disorder gives rise to Rotor syndrome. Rotor syndrome. Okay. And defect of this gene basically gives rise to Crigler-Najjar and the Gilbert syndrome. Okay. So we are clear with this diagram. Okay. Now we'll read about the unconjugated hyperbilirubinemia. We have to read about two disorders. One is the Gilbert and other is the Crigler-Najjar syndrome, which is of two types, type 1 and type 2. Type 1 and type 2. Out of these two, the most common is Gilbert. The most common is Gilbert and probably the most unharming disorder is Gilbert syndrome. So we're going to read about these disorders in a very systematic manner, right? So Crigler-Najjar 1, type 2 and the Gilbert syndrome. So type 1 inheritance is autosomal recessive. Type 2 is also autosomal recessive. Now Gilbert, if it is a promoter mutation, then it would be a autosomal recessive mutation. If it is a missense mutation, then it would be a autosomal dominant mutation. Now what would happen to bilirubin levels in these disorder? In type 1, the bilirubin would be more than 20. That is, it is more severe disorder. Type 2 would be less than 20. Gilbert, we have bilirubin less than 4 to 5. So this is the less severe disorder, Gilbert. Okay. What about Kernicterus? Now, since the bilirubin is more than 20 and it's a predominantly unconjugated hyperbilirubinemia,